Um, Hello, I'm Arvind Singh back again. Unfortunately, I had a major IT crisis here. That's why you're looking at the screen as it is. I apologize for the problem. I am unable to show my media from the laptop that I'm logged in. So you're looking at the screen now. So this is a 65-year-old lady who came in with chest pain. She had a previous history of CA breast, for which she had received chemoradiation in the past, and basically came with a CT scan where, unfortunately, I'm unable to show you that. That CT scan suggested thickened aorta. And there was no flap in the ascending aorta. There was a lot of trepidation around. The aortovascular radiologist said it looks like intramural hematoma, and therefore the suggestion of the cardiologist was, I'm not convinced, I want to do a TOE. And therefore they performed a TOE, and this is a TOE done on the intensive care unit where we are trying to regulate the blood pressure quite aggressively in this lady. And the TOE, the cardiologist performing the TOE is extremely experienced gentleman, very respected colleague. And basically he performed the TOE, and what you see here, which almost looks like a double line, was then interpreted as an artifact. And his opinion was, look, there is no dissection, there is no point in operating on this patient. Come second day, while we are aggressively managing the blood pressure, the patient becomes hemodynamically unstable. And this is still the TOE performed on the day by the expert cardiologist, suggesting that there is no dissection at all. What we're looking at is an artifact. The valve looks okay, so there's no need for this patient to go to theater. So patient still on the intensive care unit where we are controlling her blood pressure, and the following day, the patient becomes quite unstable, and you can now see this is an on-table TOE performed to assess what's the situation, and the TOE now suggests very clearly, you can see two borders here in the on the anterior aspect of the aorta. And indeed on the TOE, we could also see fair amount of pericardial collection. And you can see here very, very clear two sort of layers of the aorta going right up to the aortic root. And you can see that also on the posterior aspect. Certainly when I opened the pericardium, the patient was actually tamponading. And I had to then go ahead and do an interposition graft in this lady, which she did quite well. So basically, just increase awareness of intramural hematoma and the fact that I had alluded to in my previous talk as well, that it is something that will keep us a bit apprehensive, because we are not looking at a typical aortic dissection flap. However, it has to be entertained as an entity which can be as lethal as aortic dissection, and quite deceptively so. And therefore, less threshold and as many investigations and expert opinions as possible to try and mitigate the risk of sudden dissection going into the coronary arteries or involving the cranial vessels. So that was one of the aortic cases I wanted to show you. The other patient is basically a gentleman who had a previous aortic valve replacement. And I had performed a redo AVR in presence of very bad endocarditis in this gentleman. Following the initial operation, this patient then went home and came to us with, about 2 months later, came to us with increasing fever and as well as a small red spot, new red spot appearing in his sternal wound, and which looked like quite nice granulation tissue, basically. But what we found in the echocardiogram, and here you can't even see, this is the left ventricular outflow tract of the patient before I started the operation. What you see here moving about is actually another vegetation. And this is a full cavity underneath the valve. And you can just see the valve ring appearing in this area. And basically, this patient had developed significant and large pseudoaneurysm of the aorta with complete disruption of the valve, as you see at the bottom. Again, the color Doppler here now cutting the valve at much higher level than where you saw that particular pseudoaneurysm. And you can see flow all around the valve actually. And certainly on the anterior aspect, this whole cavity is a pseudoaneurysm into which there was a flow with every systole. This was obviously a third time operation. So I had to then cannulate peripherally in the axillary artery. This is just to show you the picture of a TOE guided insertion of a venous cannula, in which at the end you're quite reassured to see that like a double barrel or a railway track kind of two lines going into the SVC under the TOE guidance. And that's what you would like to see when you're performing peripheral bypass for these patients. It was an extremely difficult operation. The reason I showed these is to show you the pseudoaneurysm of the ascending aorta that had happened because of disruption of the valve and healing, and just to show you a couple of pictures of TOE guided cannulation. This is another gentleman who had come in with very clear-cut aortic dissection on his CT scan, but this is his TOE seen on the table. As you can see, hugely dilated ascending aorta. This gentleman was only 52 years of age, no family history of any other problems, not diagnosed with hypertension. This was his first time presentation into a hospital. And as you can see, the left ventricular contraction looks quite good, but huge flaps, almost circumferential disruption of the intima and prolapsing into the aortic valve with each beat. I requested my anesthetist to tell me what's the status of the valve. It was very difficult to interrogate this valve because however much color he would put, he was unable to assess what's happening with the valve, because as you can see, this is the short axis view of the dissection, and the whole flap is going into the aortic valve. The gentleman was otherwise metabolically quite good in theater, although the dissection had involved the descending thoracic aorta as well. So while we were cooling, and I had an extremely good team at that point, and after discussion with some of my colleagues, I ended up saving this patient's valve, performing a David's along with hemiarch replacement. The guy went home about day 10 following the operation, and I managed to save his valve. Again, the hallmark of the operation is not saving the valve in an aortic dissection setting. The first job is to keep the patient safe, make sure that you have as much possibility of having a live patient at the end, because we know that aortic dissection is a high-risk operation anyways. But very rarely you can have a situation where things look suitable, and it did on that particular day. That's the end result with the tri-leaflet valve within a new aortic root. My final patient is another patient who had an ascending aortic aneurysm. My sincere apologies, I had my CT in the presentation. We just, the slides just don't open. This lady had an ascending aortic aneurysm, which was not, I'm sorry, I think it's the wrong label here. It says at the top, post-AVR 27 mm. That's wrong. This is a preoperative echocardiogram showing a tri-leaflet valve, which is working very well, and aortic root, which is normal size. The aneurysm in this lady was limited to the ascending aorta. In this picture, you can start to see the beginning of a huge aneurysm with just above the ST junction. And this lady did not have any coronary artery disease. She was 78-year-old, otherwise quite well. Her lung function and carotid Dopplers were completely normal. And therefore, given that I perform mini sternotomy aortic valve replacements, I managed to replace this lady's valve. Managed to replace the ascending aorta through the mini sternotomy. This is again another slide to show you the insertion of the venous cannula, which is again completely TOE guided. You can actually see the guide wire in the bicual view going up into the SVC. And in the next picture, you can actually see the guide wire again going right up to the SVC, which is always very reassuring to see everything. I always feel that minimally invasive operations are to be supported by another view, and that other view in theater is going to be the transesophageal echocardiogram. These are slightly longer videos, but this is just to show you the exposure right at the beginning. We can see the innominate vein at the top and the aneurysmal ascending aorta here. I don't use any special retractors, just the usual small sternal retractor, and go up to the third intercostal space. And as you can see, it does provide a fairly quite nice exposure of the aorta. So that's the aortic pipe already in, and so I tend to put the venous pipe in the first instance. So actually, I am at this moment in time, I'm ready to go on bypass, and I actually am on bypass. This is after application of the cross clamp. You can see that we're able to actually, we'll be able to see the aortic valve quite nicely. Sorry about my colleague's cap coming in between. So that's the ST junction. You can see the aortic valve underneath. And I use a Teflon strip to reinforce my aortic anastomosis. So that's the proximal anastomosis. You can see that the aortic valve is quite nicely seen. The ST junction is quite nicely seen. And my logic was that if aortic valve can be replaced, which is further down and deeper structure through a mini sternotomy, then performing the proximal anastomosis for an interposition graft should be slightly easier, if anything. So once I've nicely reinforced the aorta here, then the sizing, chosen my graft, and started to do the proximal anastomosis. Again, exactly the same steps as I would have done in an open sternotomy with same exposure. The pipe you see here is the vent, which is into the main pulmonary artery. Most often that's supplemented with some suction through the aortic valve, usually helps us. So that's more or less completion of my proximal anastomosis. This was the test that I do. I gave the cardioplegia in the root to make sure that there is no leak around the proximal anastomosis. And then this is the distal anastomosis being performed. Distal anastomosis again is right there in front of you. Having done the proximal anastomosis, one can push the aortic valve and the root of the aortic root inside the chest, and suddenly you find that you have quite a bit of space. This is the completion of the second anastomosis, followed by dearing. This is when I have come off bypass, and its closure afterwards. That's the skin being closed. My sincere apologies for all the problems related to the IT. I would welcome more questions later on with my colleagues here. Thank you for putting up with my IT problems.